Welcome everybody to Grand Rounds for Movement Sciences and Rehabilitation for August 2023. Today we have Dr. Melinda Steimling talking to us about key considerations for rehabilitation providers, recovery in cancer survivors. Dr. Steimling received her Doctor of Physical Therapy degree from Thomas Jefferson University and completed her residency training in women's health physical therapy at Good Shepherd Penn Partners. She is a certified lymphedema therapist and a board-certified specialist in women's health physical therapy. Dr. Steimling practices pelvic health and oncologic physical therapy at Physical Therapy at St. Luke's at the third and new facility. Her clinical practice focuses on patient-centered, evidence-based rehabilitation for survivors of cancer, individuals with lymphedema, and individuals with pelvic dysfunction. In addition to clinical practice, she is an instructor for the Norton School of Lymphedema and an adjunct assistant professor at Moravian University's Doctor of Physical Therapy program. Please make sure you take the time to log into EADS and at the end of the program, take the course evaluation as well as the quiz so that you get CE or CME, depending on your profession, for this course. And we look forward to hearing your questions at the end of this presentation as well. So either type in, if you have a question, type it into the chat, or at the end of the presentation when we ask for questions, you can feel free to unmute yourself at that time and speak. We do ask that during the presentation you keep yourself on mute, just so we don't have feedback. So without further ado, I will turn it over to Dr. Steimling.
Thank you, Steve. I'd like to speak today to all rehabilitation providers because I feel it is important that we as providers are routinely screening for our history of cancer and cancer therapies so that we are able to appropriately modify our rehabilitation examinations and treatments based on the effects of the disease and cancer treatment experience itself. Here is our designation statement, and I have no financial disclosures. Today, I'm going to review common oncology terminology and describe common cancer treatments. I'm going to review common physical and cognitive side effects of cancer and cancer therapies and describe the ways to screen and modify our physical therapy examination and treatments based on the cancer status or presence of side effects in cancer survivors. So cancer is the disease that occurs when our own cells mutate and abnormally and uncontrollably proliferate in our body. If cancer grows in nearby tissue, it is called local cancer. If cancer spreads to other areas of the body, this is called metastasis. And cancer can metastasize through the blood or lymphatic system. We hear cancer being staged from 0 to 4, and these stagings describe the severity of the cancer disease. What's more clinically important for us as providers is the TNM staging system, where T stands for the size of the tumor and has a 1 to 4 scale, usually describing groups of tumor sizes in centimeters. N stands for nodal involvement. If the cancer has spread to nearby lymph nodes, there will be a subscript of a 1 next to N, or if cancer has not spread to nearby lymph nodes, there will be a subscript of 0. M stands for whether or not the cancer has metastasized or spread to distant tissues in the body. And again, it will have a subscript of 0 if there is no evidence of cancer metastasis, and it will have a subscript of 1 if there is evidence of cancer metastasis. And so this staging system is very helpful for understanding the severity of the cancer disease in an individual that may present in your clinic. Cancer is a very common disease in the US and worldwide. In this year, it is estimated that 1.9 million new cases of cancer will be diagnosed in the US alone. Luckily, survival rates from cancer have improved drastically over the last 45 years, but Currently, there are an estimated 18 million cancer survivors living in the US. To put that into perspective, 1 in 5 individuals over the age of 65 are survivors of cancer. A survivor is anyone who has been diagnosed with cancer. So a survivor may be somebody newly diagnosed that is about to undergo treatment for cancer, or a survivor may be somebody who has completed treatment but is still living with cancer. A survivor may also be an individual who has completed cancer treatments and is free of cancer. For some survivors, the consequences of cancer are minimal, and these patients can return to normal life after the completion of cancer. But the severity and complexity of anti-cancer therapies can have lasting effects on an individual for the rest of their life. So let's review some of the common cancer treatments utilized in the United States. %60 of cancer survivors undergo surgery to treat their cancer. Surgery is used to mechanically excise or remove a cancer tumor. And when this is done, it's important to recognize that cancer excisional surgeries are producing slower healing rates than non-cancer surgeries. And the reason for this is because the cancer disease itself is utilizing more of the energy of our immune system and our healing function. The lymphatic system is damaged with the surgical experience, and our lymphatic system is the system that holds our immune and healing systems. And individuals undergoing cancer surgeries may have already undergone other cancer treatments, such as chemotherapy and radiation therapy, and these will also affect the healing times after surgery. Pain and swelling are common postoperative side effects that may linger longer in a cancer survivor than other postoperative patients. Scar tissue may not heal optimally after cancer surgeries and may be a source of ongoing pain or musculoskeletal dysfunction. And the immobility that occurs in the early post-op period after surgery certainly can have effect on long-term musculoskeletal mobility and strength. During cancer excisional surgery, lymph nodes are also removed from the region of the cancer. A sentinel lymph node biopsy is a newer technique done in the last couple decades that intends to remove just a few lymph nodes that are most closely related to or connected to a cancer tumor. In removing only 1 to 3 lymph nodes, the surgeons are attempting to minimize damage or disruption to the lymphatic system in that area of the body, but also still have a high confidence in the ability to rule out cancer metastasis to those lymph nodes or to farther areas in the body. However, this small but important procedure does have side effects, such as pain in the site of the surgery, a low risk of developing chronic swelling or lymphedema, and nerve injury and damage because of the neurovascular bundles around which these lymph nodes live. Lymph node dissection is a larger surgical procedure that removes more lymph nodes than a sentinel lymph node biopsy. And this is done if cancer is already identified in a lymph node within that group of lymph nodes, and it is done to prevent the spread of cancer outside of that region of the body to other areas. Lymph node dissection is a larger procedure, so these side effects are often either more severe or more lasting, and the risk of lymphedema after lymph node dissection is a higher risk than after sentinel lymph node biopsy. Chemotherapy stems from the use of mustard gas in World War II. And chemotherapy is the administration of drugs via IV or oral medication. If it's administered prior to surgery, we call this neoadjuvant chemotherapy. And the goal is to shrink a tumor or metastasis to optimize the outcomes of surgery. If chemotherapy is administered after surgery, we call this adjuvant chemotherapy. And the goal is to target any remaining cancer cells in the body, locally or systemically, after surgery has removed the large extent of the tumor. There are lots of side effects from chemotherapy, and this is not an exhaustive list. I tried to keep it as simple as possible because it can get overwhelming. But it's important to recognize that each chemotherapeutic agent has a unique risk profile for various side effects. How chemotherapy works is it is targeting the epithelial cells from which a lot of cancers are growing and mutating, but chemotherapy affects all epithelial cells in the body. And so our skin, our hair, our nails, and our GI tract are often affected by those chemotherapeutic agents. There are certain groups of chemotherapies that have certain very important side effects to recognize. For example, the platins are those chemotherapeutic agents that often cause cardiotoxicity, and that can have an effect on exercise tolerance and our rehabilitation plans of care. Most chemotherapeutic agents cause neurotoxicity, and that is also called chemo-induced peripheral neuropathy. And CIPN is often a cold intolerance, pain, or sensory changes that are happening in the feet or the hands. It's nearly always bilateral and symmetrical in nature, and it can last for months or years. Individuals who have undergone chemotherapy for the treatment of cancer are at an increased risk of falls because of chemo-induced peripheral neuropathy, weakness, and fatigue, the other side effects that chemotherapy can induce. I mentioned that cardiotoxicity may affect exercise tolerance, but also GI upset, low blood counts, pain, and fatigue can impact exercise tolerance in survivors undergoing chemotherapy. And finally, I think it's clinically important to mention that as providers, there is a risk of environmental exposure to those chemotherapeutic agents through bodily fluids or the transfer of bodily fluids from linens and clothes, particularly if a patient is undergoing chemotherapy while receiving rehabilitation services and you're working with them at the same time. But this environmental exposure is a consideration for months after chemotherapy is completed for the survivor. So I recommend considering wearing gloves and exercising universal precautions when treating a survivor who has recently undergone chemotherapy. Radiation therapy was first attempted in around 1900, but was not perfected until the 1950s to be utilized for cancer treatment. How radiation therapy works is that an energy beam is ionizing atoms in our cells, and this damages the DNA of our cells, which prevents replication or even induces cell death. And radiation is targeting those rapidly dividing mutated cancer cells, but radiation actually affects all of the cells in the area of the radiation field. Has some pretty significant side effects. Fatigue is a side effect of radiation because of the immense demand on our immune system to heal that entire radiation field after radiation therapy. It takes a lot of metabolic energy and can create a widespread fatigue. More notably, that I want to spend time on is the soft tissue and vascular damage and fibrosis that is imminent after radiation therapy. Fibrosis happens because of endothelial cell damage and local chronic inflammation in the radiated tissue. Radiation creates microvascular necrosis or necrosis of our capillary beds, which can lead to local ischemia and poor blood flow to the skin and the other superficial tissues. I want to really emphasize that irradiated tissue is fragile, stiff, has poor blood flow, and usually has edema. And that this effect of radiation on the soft tissue within the radiation field happens immediately with radiation therapy, but may not be clinically evident for months to years after completion of radiation. We call radiation the gift that keeps on giving because these side effects may present later in life, but are a lifelong progression. There's this large category of biologic therapies that I'll review briefly. It includes bone marrow transplant, which is the delivery of healthy stem cells to replenish our bone marrow. And this is used for leukemia, lymphoma, and multiple myeloma treatments. The side effects of graft versus host disease are not commonly seen in the outpatient rehabilitation world, but it does require immunosuppression treatment, which can have effect on community access for these individuals. Immunotherapy is a treatment where we upregulate or genetically modify our T cells to improve our body's natural cancer fighting response. And it has less intense side effects than chemotherapy, and it's growing in its usage within US cancer treatment. Targeted therapy is a group of biologics that are targeting specific functions of a cancer cell, and so it's highly individualized to each type of cancer. And then lastly is hormone therapy, usually in the form of androgen suppression, and this is used for the treatment of breast and gynecologic cancers. And it's important to recognize that hormone therapy is a long-term medication, and the side effects of it, most notably for the rehabilitation considerations, are osteoporosis, fatigue, muscle and joint pain, and the risk of blood clots. As rehabilitation providers in the outpatient setting, it is important that we are routinely screening for a history of cancer diagnosis, and then screening and addressing the many physical side effects of cancer and cancer therapies. We also have a role in promoting wellness practices, such as sleep hygiene, weight management, and unsupervised exercise, as all of these can reduce the risk of cancer recurrence. And as I mentioned, that survivors are termed as such from the moment of diagnosis through the remainder of their life. We can recognize that rehabilitation of a cancer survivor may happen at any point months to years post-diagnosis and post-treatment, but we must still consider all of the implications of that cancer experience for that individual. So I'd like to present I'd like to present an article by Alapatu that was a retrospective case review of about 400 individuals, survivors of cancer, who were referred to an outpatient physical therapy office. And they were looking at the characteristics of these survivors in the rehab setting. Like the general population of adults, the most frequent comorbidities of cancer survivors are hypertension, diabetes, and arthritis. The impairment seen in cancer survivors was most notably strength and soft tissue integrity, which is radiation fibrosis, scar tissue restrictions, or lymphedema. Pain and fatigue should be screened in any survivor who has undergone radiation therapy, according to Alapatu. Lymphedema is most often seen in breast cancer survivors versus other types of cancer survivors. And urinary incontinence is most often seen in genital urinary cancers or gynecologic cancers. And so these could be specifically screened for these types of cancer survivors. They also recognize that the duration of physical therapy treatment for musculoskeletal impairments was affected by the number of cancer therapies that a survivor had undergone, and recognized that chemotherapy resulted in a slower recovery through the rehabilitation experience and therefore a longer duration of physical therapy. So I want to introduce Jane, who is a 67-year-old female that presented to outpatient physical therapy. And I treated her a few years ago, but she's very representative of an individual that may be seen in many outpatient rehabilitation settings. She presented to PT for right neck and shoulder pain. And right neck and shoulder pain is a very common diagnosis that physical therapists treat. And I want you to take a moment and think about your usual approach to treatment of right neck and shoulder pain. So I start with an interview. And in addition to learning the nature of Jane's pain, in which it was in that right neck and upper scapular region, it was moderate to severe in intensity, constant but fluctuating in intensity. Nothing could relieve it. It affected her sleep and her ability to perform overhead activities. She also felt like she had headaches related to that neck pain. I asked her if she had a diagnosis of cancer, and she said, yes, she has been diagnosed in her past. And so I dove into that screening and garnered that she was diagnosed with right breast cancer a year prior. She had undergone surgery, and she had undergone a lumpectomy and sentinel lymph node biopsy, in which they did remove 2 lymph nodes from her axilla, and one was found to be infiltrated with cancer. And therefore, she was given a diagnosis of stage 2B breast cancer. You can see the TNM staging in the slide here, where her tumor size was small to moderate. She had positive nodal involvement, but she did not have evidence of metastasis outside of the chest and axilla region. After her surgery, she received chemotherapy, and she underwent chemotherapy for 2 months. And after that, she received radiation to her chest. And those 32 doses were extended over 2 months. She was currently on Arimidex, which is a hormone suppression medication, and would be on it for 5 years. So I had a better picture of her cancer diagnosis and her cancer treatment experience, all of which had finished up about 3 months prior to physical therapy evaluation, except for the ongoing Arimidex. So I asked her if she had experienced any side effects during or shortly after her treatments, or if she was continuing to experience any side effects that she associated with her cancer treatments. And she described bone pain, headaches, nausea, and this neck and shoulder pain for which she was seeking treatment. All of these side effects she described as being a daily occurrence, but the neck and shoulder pain was most bothersome. So typically for a physical therapy examination of neck and shoulder pain, we are examining the cervical spine, the thoracic spine, the shoulder girdle, including the scapula and the upper extremity. And I want you to consider how we might want to modify this examination for a breast cancer survivor. And I'm going to digress a second and ask how many of you are visualizing the scapula as you're evaluating the upper quarter. How many of you feel comfortable asking a patient to expose the scapula by moving or removing upper half clothing so that you can visualize the surface anatomy over this entire upper quarter? And the reason I digress is because this is an important modification and component for an examination of the upper quarter in a breast cancer survivor. I recommend that we are visualizing not just the scapula on the posterior thorax, but the area that has been treated multiple times for the cancer disease. And that includes the axilla and the chest wall and the breast. We know that there are scars in these areas for breast cancer survivors, and there's likely edema in the area or radiation fibrosis. So it's important that we can visualize and palpate and screen for these side effects of the cancer treatments. And that requires comfortability with explaining to your patient the rationale for observing and palpating the chest and the breast, and for knowing what you are looking for. I also recommend that we screen for lymphedema in all cancer survivors, particularly breast cancer survivors. And we can do so visually by comparing the arm on the side of the breast cancer to the arm on the other side. We might see differences in the ability to visualize veins and ligaments and tendons in the hand, or the shape and prominence of our knuckles. We may see differences in the circumference of the forearm, the elbow, or the upper arm. And this screening can then trigger a referral to appropriate treatment. I also recommend screening for chemo-induced peripheral neuropathy, fatigue, and balance impairments, as these are known side effects of multiple treatments for cancer. I also want to make a note that prone lying may be intolerable for cancer survivors shortly after cancer surgeries or radiation to the front side of the body, and therefore you should expect to modify your examination positioning if prone lying is intolerable. So all of these are additional examination components that I encourage you to implement routinely with cancer survivors, in addition to your standard cervicothoracic, spine, and shoulder examinations. As we're examining cancer survivors, it's important to keep in mind that there are some cancers that tend to metastasize to bone. And as we are examining the musculoskeletal system, it's important to keep in mind some of the clinical signs that may indicate a bone metastasis that may not have been diagnosed yet, or a cancer recurrence that also has gone undiagnosed. And so these can be in the back of your mind, and this is a brief list here. Additionally, cancer tumors, particularly of the breast and lung, may grow to the extent that they may compress the brachial plexus. Or abdominopelvic cancers, such as colorectal and gynecologic cancers, may grow and compress upon the lumbosacral plexus. And so this is a reminder that progressive dermatomal or myotomal symptoms or unrelenting pain that does not seem mechanical and does not fit a typical clinical pattern could be a sign or concern for neural compression of either an undiagnosed tumor, a growth, or recurrence of cancer. I also tried to keep this slide as simple as possible, but was not successful, because I've listed for many of those cancer treatments that these side effects are common. And therefore, it is important to screen for these side effects in most cancer survivors that walk through our door for musculoskeletal treatment. And often the screening is as simple as a question or a questionnaire, but sometimes it requires a little bit more extensive use of monofilaments, or balance screening can take a little bit longer than fatigue screening. If you have questions about screening methods, I encourage you to reach out to me. The Academy of Oncologic Physical Therapy is routinely updating their screening recommendations based on review of the literature. And so this is about as up to date as I can get. Circling back to Jane, my 67-year-old woman with right neck and shoulder pain, I want to talk about my examination. First, I looked at the quarter or the quadrant in question. I looked at her neck, I looked at her chest wall, and I looked at her posterior thorax and her right shoulder. I found moderate amounts of lymphedema in her right breast. It was swollen and heavy. There was, to the touch, mild to moderate amounts of radiation fibrosis of that right breast tissue that had been radiated. The skin was thicker and stiffer. She had scars in her axilla and on the lateral breast that were painful to palpation. And she described to me later in the exam that it hurt in those scars when she raised her arm over her head. Her shoulder range of motion was moderately limited, particularly into functional internal and external rotation, and it was mostly pain limited by her neck and shoulder pain and chest pain. And her shoulder strength was pretty good, given that she had just gone through 9 months of cancer treatment. Circle back to my plan of care for her based on that examination. But I'd like to talk about the role of rehabilitation and the modifications for cancer survivors to our physical therapy plan of care based on the literature. So the American College of Sports Medicine has specific guidelines for exercise for cancer survivors, and an independent international roundtable also created their own exercise guidelines more recently. Both of them found that exercise is safe and beneficial to cancer survivors, and that exercise does not interfere with the effectiveness of anti-cancer therapies. There is strong evidence that exercise can address mood disorders, quality of life and function, pain, fatigue, and lymphedema. And there's moderate evidence that exercise for cancer survivors can improve bone health and sleep. These same two position statements outlined recommendations for what types of exercise are beneficial and safe for cancer survivors. And similar to the recommendations for exercise for the general population, aerobic exercise should be engaged, and it should be moderate to vigorous in intensity if tolerated. Resistance training is safe and should be moderate intensity for most cancer survivors. Stretching may be beneficial, particularly after those cancer treatments that can affect tissue mobility. However, it is established that we should use caution when performing sustained end range stretching movements or position. What this means is that stretching should be low intensity and modified to limit end range stretching. There are other guidelines for specific cancer-related issues. As cancer survivors have a risk of bone metastasis, we need to be protective of bony disease. And that means avoiding loaded end range movements and rapid end range movements, and emphasizing controlled movement, good technique, and postural alignment. Additionally, because of the risk of fall-related fractures, fall risk reduction education and intervention is a great idea with survivors living with bone mets. These guidelines, I also say, would be beneficial for any patient with osteoporosis or at risk for osteoporosis, such as women who are on hormone suppression therapy after breast cancer. There is a long list that the National Comprehensive Cancer Network has published within their survivorship clinical practice guidelines. And this list is of those situations that cancer survivors may have that put them at a high risk for adverse events with exercise. And so screening for these things is important in cancer survivors because within this list are long-term side effects, such as ostomies, cardiopulmonary comorbidities, and lymphedema. The International Roundtable that published exercise guidelines in 2019 also has the position that all fitness professionals should be familiar with cancer treatments the side effects of cancer treatments, and the impact on exercise tolerance. And I did try to touch on this today, so hopefully you are feeling more comfortable with it. And we have to recognize that exercise tolerance and the treatments and the side effects of treatments really do differ based on the type of cancer, the stage of the disease, and other patient comorbidities. So it's important to recognize who can initiate exercise within supervised rehabilitation, such as our role, and who can exercise without supervision in the community, and which cancer survivors may require more specific medical screening before initiating any sort of exercise. And so these guidelines are listed in the red box below. There's two different ones that are very similar, and they can be very beneficial if you are treating a cancer survivor and initiating exercise when they have not previously done so after their cancer experience. In addition to aerobic and strengthening exercise for health and wellness and rehabilitation, as rehabilitation providers, it's important that we consider including balance training and fall prevention strategies into our plans of care, because we know that balance and neuropathy and falls are a frequent comorbidity of cancer survivors. Additionally, we can play a role in fatigue management through pacing and energy conservation, but also through exercise. And in addition to the survivorship guidelines by the National Comprehensive Cancer Network, there are cancer-related fatigue clinical practice guidelines through the American Physical Therapy Association and NCCN. Manual therapy is a frequent tool that rehabilitation providers utilize to address soft tissue impairments for anybody. And manual therapy may be an important component of your clinical practice and of your ideal plan of care for a cancer survivor. However, there are some elements of manual therapy that may need to be modified for cancer survivors. Of note, grade 5 joint manipulations or thrusts are contraindicated if there's osteoporosis, bone metastasis, spinal cord compromise from tumors, or skin integrity issues. And in general, grade 5 joint mobilizations are discouraged in and around the radiation field for the rest of that individual's life because of the risk of bone disease and osteoporosis as a result of radiation. We know that the skin integrity of cancer survivors is impacted by radiation, and therefore instruments are discouraged from use on the area of the radiation field, be it cupping or Grafton or other instruments. We've talked about how chemotherapy slows healing times, and the effect on blood counts also puts tissue in a more fragile state, and using instruments on that skin or soft tissue is not recommended. And finally, I've talked about how surgery has slower healing rates than other types of soft tissue surgeries, and therefore instruments are not a good idea to utilize in and around the surgical site, certainly in the early post-op period, but perhaps for a longer duration of time after the cancer treatment experience for a survivor. So what I recommend is that we utilize our hands the most if we are seeking to apply specific manual therapy techniques to an area of the body that has undergone cancer treatments. Additionally, at this point, it shouldn't be a surprise that thermal modalities are generally contraindicated in the area that cancer has occurred for any survivor at any point in the survivorship experience, because if that skin is compromised from some of the cancer treatments, particularly radiation, that compromise is lifelong. Transcutaneous electric stim is generally contraindicated in the presence of active cancer, but also it may not be recommended on that compromised skin henceforth after cancer treatment or even after remission. Circling back to Jane, my 67-year-old cancer survivor who had neck and shoulder pain. I ended up treating her for 10 visits over 8 weeks. And on that first visit, I chose to focus on her breast edema and radiation fibrosis because I knew that that chest wall was pulling and weighing down on her clavicle and her shoulder girdle more than it had been pre-treatment and in a constant fashion that contributed to her constant pain. Therefore, I gave her a foam compression pad to put in her bra and educated her about other strategies for edema management. I taught her a gentle skin stretching technique called manual lymphatic drainage that is very effective in promoting the movement of edema out of soft tissue. And it's also very effective in starting to soften the fibrosis that happens in the skin after radiation. On the second visit, she was starting to feel better, so I utilized my own hands to mobilize the edema, soften the fibrosis, and start to perform some gentle scar mobilization. She felt ready to initiate some gentle upper quarter stretching. And the two that I typically focus on with breast cancer survivors initially is thoracic extension, active range of motion, and gentle pectoral stretching or shoulder abduction stretching. Later in my plan of care, I initiated strengthening exercise, both because she had functional limitations with overhead reaching and lifting up her grandkids, but also because I wanted to establish a lifelong resistance exercise program for her to continue unsupervised, as it has clear benefits on quality of life, functional activities, and on lymphedema management. So some of the other interventions I provided on visit 6 through 10 include the arm bicycle progressively, and incline walking for cardio aerobic benefit. And my strengthening exercises, these are just a few pictures here, but I do focus on serratus activation and strengthening because it's often stiff, sluggish, and a little shut down after breast surgery as well as after radiation to the chest wall. And other strengthening activities included overhead strengthening and pulling motions and grip strength. So Jane did very well with 8 weeks of physical therapy and 10 visits in those 8 weeks. Interestingly, her headaches and her nausea were the first thing to resolve within the first 2 weeks, within the first 3 visits. And I did not necessarily expect this because those are side effects of chemotherapy typically, but it appears that they were also side effects of lymphedema and the shoulder girdle pain. Her pain reduced to a 1 out of 10 with daily life within those first 4 weeks, and her range of motion improved because she was no longer pain limited. And at visit 6, she was feeling quite good, but again, wanted to be able to lift her grandkids without difficulty or pain. And she verbalized to me, "I am ready to start strengthening." And that was a very exciting time. So that is why we spent 4 to 5 visits focusing on establishing a long-term strengthening program for her. Finally, she did experience a flare in lymphedema, and this flare resulted in a flare of nausea and headaches, interestingly. And I was able to help her navigate that flare during our course of care because flares in lymphedema are going to happen because it's a lifelong chronic diagnosis after cancer treatment. And helping patients to learn how to self-management is a really good tool that we should utilize. Lastly, I want to mention that within the world of outpatient rehabilitation and survivorship, there are a whole host of professionals that can help our survivors to improve their quality of life and to address all of those other side effects that I did not have time to talk about today. And so here's a nice list, and it's not exhaustive, and it may vary in each of our communities, but it is important that we seek out these referrals if we're screening and identifying for side effects related to these specialties. I want to thank you for your time today, and I'll open the floor to questions.
So if you have any questions, please feel free to type it into the chat. Unmute yourself and ask. I do have one question.
This is Liesl from physical therapy over in New Jersey side. And I've had several patients who were very poorly educated on the effects of radiation to their bodies, coming in months, weeks, years after injury from the radiation with stiffness and tightness. And they're going, why is my neck so stiff? Why can't I move this way or that way? I even have a patient right now who has actually some vestibular disorders from the cyber knife treatment that she was given for an acoustic neuroma. She has much less other issues, but when she brought it up to the doctor, they're like, oh no, that's not from this, which is kind of frustrating given all the research you just presented. So any suggestions on why that might be happening when this research is out there, as well as how to address it with a patient and help them find the resources and educate themselves long term?
Great question. And I understand the frustration that you may have experienced or your patient may have experienced. And I think that this research is not new research, but it's continuing to evolve, and the conversations are happening more and more often in a multidisciplinary way. I do understand that each of the medical professionals within the oncology world are very focused on their immediate goals. And therefore, while everyone has the patient's best interests at heart, they are dedicating their time to their immediate specialty, be it surgery or the radiation science or the chemotherapy science. And oftentimes these patients are discharged from these active cancer treatments and those care teams before their symptoms may present. And so it is not as often that providers may be making that link between symptoms and the cancer therapies. But there are lots of great providers that are recognizing and educating patients in advance or being proactive about referring them to rehabilitation as needed.
I have a question. Well, as an orthopedic provider, listening to that case, I'm hearing night pain, personal history of cancer, and upon observation, a flare of lymphedema. My alarms are going off, and I appreciate that you would treat this patient, but I'd love to hear a little bit more about your thought process of what led you to determine to treat that patient, as opposed to what I probably would do in that situation is refer, because I would feel very concerned of metastasis.
Yes, and thank you. That's a fantastic point to make, and definitely something that I wasn't sure I had time to really expand upon. So thank you. Part of my clinical reasoning is the timeline of events. The patient was 3 months out from radiation therapy, so she had just seen a lot of her medical team within the last few weeks. The timing of her symptoms had been for weeks to months, so she had spoken about these to her other doctors, and they had endorsed a referral to physical therapy. Additionally, within this first year after cancer, the risk of a new recurrence is rather low if she had been deemed completed of her treatments. If that cancer disease process was not stable or minimal, then she would still be actively undergoing cancer treatment. So I think the final component is really the fact that she was still very closely communicating with her oncology team already, and they were aware of these symptoms. Yeah.
Any other questions? All right, thank you very much for that wonderful presentation. If anybody has any further questions, please feel free to reach out directly to Dr. Steimling, and make sure that at the end of this presentation you complete the course evaluation and the quiz, and to get your CE credit or CME credit. Thank you very much, and we look forward to seeing you again next month. Thank you for everybody who attended in person.